Welcome back to our Sante Pharmacy Academy. My name is Massa. You can call me Emma as well. I'm a registered pharmacist here in Ontario, and this is video number 2 in our Minor Ailments series. If you're new here, we are two Canadian pharmacists, and our goal is simple, free, evidence-based pharmacy education for pharmacists, pharmacy students, and anyone who wants to stay sharp in practice. Last time we covered acne vulgaris. Today we're moving alphabetically to our second minor ailment, allergic rhinitis. This one is incredibly common, and it's one of those conditions where how you manage it in the pharmacy actually makes a huge difference for your patient's quality of life. So whether it's the patient sneezing through allergy season or the one who's been on Benadryl every day for 6 months, this video is for you. Let's get into it. Okay, here is my disclaimer and disclosure. So this video is for pharmacists, pharmacy students, and it's not a substitute for clinical judgment, individual patient assessment, or professional advice. Content reflects Ontario community pharmacy practice and Canadian guidelines, and guidelines may differ in different provinces and or countries. No sponsorship, funding, or commercial relationship influence this content. Products mentioned are for educational reference only. Viewers should not use this content to self-diagnose or self-treat. Always refer patients to appropriate healthcare providers. Medical guidelines evolve. Always verify recommendations against current evidence and your provincial regulatory standards. And please practice within your own scope and jurisdiction. So, what exactly is allergic rhinitis? The definition: it is an IgE-mediated inflammatory response of the nasal mucosa to inhaled allergen. In plain language, the immune system is overreacting to something in the air, and the result is that classic combination of congestion, runny nose, sneezing, and itching. Now let's talk about how common this is. About 25% of Canadians are affected. That is 1 in 4 patients walking into your pharmacy. This is not a rare condition. This is one of the most common things you will see in practice. The main triggers: pollen, dust mites, pet dander, and mold. Symptoms can begin at any age, though we see peak onset during childhood and adolescence. Regarding the classification in the right side, as we see on top, classification matters here. We have like 2 axes, and why it matters? Because it drives your treatment decisions. Axis 1, seasonal versus perennial. Seasonal allergic rhinitis actually triggered by outdoor allergens such as trees in spring, grass in early summer, ragweed in fall here in Ontario. Perennial allergic rhinitis, it is year-round, driven by indoor allergens like dust mites and pet dander. Axis 2, intermittent versus persistent, and mild versus moderate to severe. This is from ARIA guidelines. Intermittent symptoms less than 4 days per week or less than 4 weeks total. Persistent equal or more than 4 days per week and equal or more than 4 weeks. How about mild? Does not affect sleep or daily activities. And moderate to severe is impacting quality of life, sleep, work, school, recreation. In both frequency and severity matter when deciding how to treat. Keep that in mind throughout this video. Okay, let's talk about what's actually happening in the body. Because understanding the mechanism helps you explain it to patients and helps you understand why different drugs work. There are three phases. Phase 1, sensitization. This happens on the first exposure to an allergen. The immune system recognizes it as foreign. Beta cells are activated. Ig antibodies are produced, and these Ig antibodies bind to the mast cells in the nasal lining. Nothing happens yet. The patient has no symptoms, but the immune system is now primed. Phase 2, early phase reaction. Now the patient is exposed to that allergen again. The Ig antibodies and the mast cells are cross-linked by the allergen, triggering mast cell degranulation. Within minutes, histamine, leukotrienes, and prostaglandins flood the nasal mucosa. This is what causes the sneezing, the runny nose, the itching. The early phase is histamine driven. This is why antihistamines work so well for those symptoms. Phase 3, late phase reaction. About 4 to 8 hours later, eosinophils and basophils are recruited to the area. This is a sustained, ongoing inflammatory response, and this is where nasal congestion really dominates. The late phase is not well controlled by antihistamines alone, which is exactly why intranasal corticosteroids are so important for congestion. Key symptoms here to mention: sneezing, rhinorrhea, congestion, nasal itching, postnasal drip, and in about 50% of patients, they have eye symptoms as well, which is called allergic conjunctivitis. Now we get into how to actually assess this in the pharmacy. We're using our Scholar Mac framework, the same one we used for acne, because it gives us a consistent systemic approach to any minor ailment presentation. Here are the key questions for allergic rhinitis specifically. So let's start with S, symptoms. What exactly is the patient experiencing? Sneezing, runny nose, congestion, itching, eye involvement, and are symptoms worse indoors or outdoors? This helps you distinguish seasonal from perennial. C, characteristics. What does the discharge look like? Is it clear and watery? So it strongly suggests allergic. Thick, yellow, or green suggests infection. Is it bilateral? Allergic rhinitis is always, remember it, always bilateral. We'll come back to this when we talk red flags. History. Does the patient or their family have a history of atopy, asthma, eczema, other allergies? This is one of the strongest supporting pieces of evidence. Oh, onset. Is this new or a recurrent problem? Did symptoms start in spring, like tree pollen, early summer, grass, fall, ragweed, or is it year-round, such as dust mites or pet dander? L, location. Purely nasal, or is there throat irritation, eye involvement? Eye symptoms suggest allergic conjunctivitis coexisting, so at the same time. Aggravating, What makes it worse? Outdoors on high pollen days, around cats, in a dusty room, knowing the trigger guides avoidance counseling. Relieving. Has the patient tried anything? Do antihistamine help? Response to antihistamines is actually supporting evidence for an allergic cause. Okay, now you see the box below, the navy blue, which is our MAC. So regarding the MAC, MAC, you see medications, allergies, conditions. So medications, what has the patient tried? Prescription, over-the-counter, nasal sprays. Allergies, any drug allergies relevant to what you're about to prescribe. Conditions, asthma, nasal polyps, deviated septum, hypertension, glaucoma, BPH, these are all affect which medications are safe. Before you prescribe anything, stop here. Red flag first and always. Any of these findings means you do not prescribe, you refer. Red flag number one, unilateral nasal symptoms. This is the big one. Allergic rhinitis is always bilateral. If a patient has symptoms and only on one side, one nostril block, discharge from one side, that is a red flag. Could be a nasal polyp, a foreign body, or in the worst case, a malignancy. So refer the patient. Red flag number two, purulent or bloody discharge. Clear, watery discharge is typical of allergy. Thick, green, or bloody discharge is not. It could indicate bacterial sinusitis, granulomatous disease like Wegener's, or structural pathology. So refer the patient. Red flag number three, severe facial pain or headache. Not a feature of uncomplicated allergic rhinitis. Think sinusitis, orbital involvement, or intracranial extension. Refer urgently. Red flag number four, anosmia. Loss of smell points to nasal polyps, chronic sinusitis, or post-viral olfactory dysfunction. All beyond minor ailment scope. Again, refer the patient. Red flag number five, systemic symptoms such as fever, weight loss. Allergic rhinitis doesn't cause fever or systemic illness. If present, something else is going on. Refer. Red flag number six, failed appropriate treatment. So if a patient has already tried optimized therapy, such as intranasal corticosteroid plus antihistamine for 4 to 6 weeks with no improvement, refer to an allergist. And last but not least, red flag number seven, suspected nasal polyps, visible polypoid tissue, bilateral severe blockage, reduced smell. Refer the patient to an ENT. Now let's move on to the patients who don't have red flags. And those are the ones who we can help. Okay, for you to prescribe for allergic rhinitis, as an Ontario pharmacist under the Minor Ailments framework, you need to establish a clinical diagnosis. Good news, no allergy testing is required. Minimum diagnostic criteria, at least 2 of the following nasal symptoms present for at least 1 hour on most days. Nasal congestion, rhinorrhea, it could be anterior or posterior, nasal itching, sneezing. Supporting clinical evidence. Here, You see, the following increase your confidence in the diagnosis. First, personal or family history of atopy, asthma, eczema, or other allergies. Single strongest predictor. Second, clear watery rhinorrhea, not thick, not purulent. 3. Pale or bluish nasal mucosa on inspection, boggy, edematous appearance. 4. Seasonal pattern, worse in spring, summer, or fall. 5. Known trigger, cat exposure, pollen, dust reproducibly, causes symptoms. So, and number 6 is response to antihistamines. Prior over-the-counter antihistamine helped. So diagnosis is clinical. No skin prick test or serum Ig required for Ontario minor ailment for you to prescribing. Your clinical assessment is sufficient. Now let's talk treatment. We use a stepwise approach based on symptom severity. Step 1. Allergen avoidance. All patients. Foundational for all patients, regardless of the severity. HEPA filters, encasing mattresses and pillows, reducing indoor humidity, keeping pets out of the bedroom, monitoring pollen counts. These are the non-pharmacological, there's no side effects, and it works. Step 2. First-line pharmacotherapy, intranasal corticosteroids, preferred first line for moderate to severe allergic rhinitis. This is in the ARIA guidelines, the Canadian guidelines, everywhere. More effective than oral antihistamines for nasal congestion and overall symptom control. For mild or intermittent allergic rhinitis, a second-generation oral antihistamine is appropriate. Cetirizine, loratadine, or fexofenadine. For moderate to severe disease, combining intranasal corticosteroid with a second-generation antihistamine gives the best symptom control. So intranasal corticosteroid addresses late phase congestion. Antihistamine handles early phase sneezing and itch. Step 3, add-on or second-line agents if step 2 isn't enough. Intranasal ipratropium for watery rhinorrhea. Intranasal decongestants, short-term congestion relief only. Oral decongestants with caution. Montelukast, modest benefit, that's especially useful when asthma coexists. And here is our key message. Intranasal corticosteroids are the most effective monotherapy for allergic rhinitis and is superior to oral antihistamines for nasal congestion. When in doubt, start with intranasal corticosteroid. Let's look at the intranasal corticosteroid options in detail. On this slide, you can see the full table of options available in Canada. So what are the available intranasal corticosteroid products? Fluticasone propionate, Flonase, Avamys is over-the-counter available product in Canada. 2 sprays in each nostril once daily. Mometasone furoate, prescription only, approved for 2 years and older, great in pediatrics. Budesonide, Rhinocard, over-the-counter available, a strong safety profile, and it's preferred intranasal corticosteroid in pregnancy. Triamcinolone acetonide, a nasal quart. It is over the counter available, and same as the other ones, it's like 2 sprays in each nostril once daily. Cyclazonide, Omnaris. It is prescription medication with minimal systemic absorption. It's a prodrug activated at nasal mucosa. And last but not least, beclomethasone, beconase, older agent. Twice daily dosing can affect compliance. Okay, now let's go to the key counseling points for intranasal corticosteroid. So counseling on intranasal corticosteroid techniques is critical. This is the number one reason intranasal corticosteroids fail in practice. So the patient comes to pharmacy, the patient has the right drug, the right dose, and they're using it wrong. So what to tell every patient? First, prime the spray if it's new or unused for 2 weeks, 6 actuations. Aim toward the outer wall of the nostril, toward the ear, not the septum. Aiming at the septum causes nosebleed. Most patients aim right at the middle. Inhale gently through the nose while actuating. Breathe out through the mouth and do not sniff hard. This carries drug down the throat. Use regularly every day, not as needed. Full effect takes 1 to 2 weeks. Some congestion improvement within a few days. Then wipe the nozzle and replace the cap after use. Regarding the onset expectations, remember, congestion improves in 1 to 3 days, full benefit in 1 to 2 weeks. Set this expectation up front or the patient will stop the spray after 3 days and say it didn't work. Let's talk about antihistamines. Your drug choice here matters. And the most important distinction is second generation versus first generation. Second generation antihistamines preferred cetirizine, called reacting, 10 milligram once daily. It has rapid onset, may cause mild drowsiness in some patients. Loratadine, Claritin, 10 milligram once daily. Least sedating of the group. Go-to for elderly, drivers, people sensitive to drowsiness. Fexofenadine, Allegra, 120 to 180 milligram once daily, most studied, and it has minimal central nervous system effects. Desloratadine, 5 milligram once daily. This is the active metabolite of loratadine. Belastine, 20 milligram once daily, must be taken on an empty stomach, and food significantly reduces the absorption. First generation antihistamine, just use it with caution. First generation antihistamines cause significant sedation and anticholinergic effects. So avoid it in elderly. It comes from the guideline Beer's criteria. And avoid in children under 12 for rhinitis. Avoid for anyone who drives or operates machinery. Diphenhydramine, Benadryl, significant sedation, dry mouth, urinary retention, and confusion. Chlorpheniramine, chlortripone, impairs psychomotor function, but not recommended for rhinitis in children less than 12. So for intranasal antihistamine, um, underused and effective as a lasting, twist phrase, perignostrol 2 times daily. It has the fast onset, about 15 minutes, and warn patients about the bitter taste. Olopatadine, 2 sprays in each nostril 2 times daily. It is less bitter, good for eye symptoms too, as we mentioned, for like eye conjunctivitis. For special population in pregnancy, loratadine is category B and it's preferred. Avoid first generation antihistamine. For pediatrics, cetirizine syrup for 6 months and older. Loratadine is for 2 years and older. Again, avoid the first generation under 12 years. And for elderly, loratadine is preferred. Avoid again first generation. It has the fall risk, urinary retention, and confusion. Okay, now let's get into other pharmacological options. Intranasal ipratropium, atro and nasal. Targets watery rhinorrhea, specifically 2 sprays of 0.03%, 3 times to 4 times daily, and it doesn't help congestion or sneezing. It's a targeted agent for rhinorrhea. Cromolyn sodium, nasal chrome, mast cell stabilizer, works best prophylactically, so start 2 weeks before allergy season. It's not useful once symptoms are active. It's very safe for pregnancy and children. Montelukast, modest benefit for rhinitis alone, more attractive when asthma coexists, and not first line for rhinitis per Canadian guidelines. Saline nasal irrigation, NailMed Anedipod, first line adjunct for all patients, 240 ml isotonic or hypertonic saline, clears allergen load, thins secretions, helps intranasal corticosteroid works better, and is safe in population. Now let's get into the special populations. Pregnancy. Budesonide intranasal corticosteroid is category B, most safety data, plus loratadine antihistamine. Avoid oral pseudoephedrine, especially in the first trimester. In pediatrics, 2 years and older, mometasone or fluticasone intranasal corticosteroid. Cetirizine syrup for like more than 6 and older than 6 months old. Avoid first generation antihistamine for less than 12 years old. In elderly, intranasal corticosteroids preferred. Loratadine if antihistamine is needed. And avoid pseudoephedrine because of the side effects. It can increase the hypertension, lead to hypertension or urinary retention. In patients with hypertension and cardiovascular disease, avoid oral pseudoephedrine. Short-term intranasal oxymetazoline is okay. So basically, intranasal corticosteroids plus second generation antihistamines, safe. In patients with glaucoma and BPH, avoid anticholinergics and the first generation antihistamine. Saline plus intranasal corticosteroid is the safest option. Okay, now let's spend time on decongestants, specifically when to use them and when not to. Intranasal decongestants such as oxymetazoline, the brand names Durstan, Atrovan. They're very effective for acute congestion, rapid onset within minutes. Maximum 3 days use only. It could be 2 sprays per each nostril 2 times daily, but again, don't forget maximum 3 days only. Using longer causes rhinitis medicamentosa. It's a rebound congestion, and the nasal mucosa becomes dependent on the drug. When it wears off, the nose swells worse than before. What is the management of rhinitis medicamentosa? Stop the nasal decongestants and bridge with an intranasal corticosteroid. So the intranasal corticosteroid treats the rebound inflammation while the patient wears off the oxymetazoline. Oral decongestants, pseudoephedrine, the effective oral decongestants, but note here, phenylephrine oral has been shown in recent studies to be no more effective than placebo. How's the dose? 30 to 60 milligram every 4 to 6 hours or 120 milligram extended release twice daily. But it has its own side effects such as elevated blood pressure, tachycardia, insomnia, anxiety, urinary retention. And now let's get into the contraindications and cautions. In patients with hypertension, cardiovascular disease, glaucoma, BPH, concurrent MAO inhibitors, patients over 60, pregnancy, especially first trimester. So use pseudoephedrine carefully and selectively. Always check the patient's medical history and medications first. Okay, now counseling pearls and monitoring. So regarding the intranasal corticosteroid nasal spray technique, it was covered in detail on slide 8, but here is the summarize and the key points. First of all, prime it, aim it toward outer nostril wall, inhale gently, use every day consistently. Trigger avoidance counseling. Check pollen counts before outdoor activities. You can use the weather app, aerobiology research labs. Keep windows closed on high pollen days. Use AC with HEPA filter. Shower after outdoor activity removes pollen from hair and skin. Vacuum with HEPA filter. Wash bedding weekly in hot water. Consider saline rims after allergen exposure. Never forget setting patient expectations. Underrated clinical skill. This is one of the most important parts of the encounter. If you don't set expectations, patients give up on effective therapy too early. Antihistamines, symptom relief in 1 to 2 hours. So fast. Intranasal corticosteroid, partial congestion relief in 1 to 3 days, and the full benefit at 2 weeks. Intranasal corticosteroid must be used every day, not as needed. Consistency is everything. Reassess in 4 to 6 weeks if not controlled. And then review and possibly refer. Regarding the follow-up and monitoring, assess symptoms control. Are they sleeping better, able to function at work or school? Check for adverse effects. Intranasal corticosteroid can lead to nosebleed, irritation. Antihistamine, the oral ones can lead to sedation, Decongestant can increase the blood pressure. So if it's moderate to severe persistent allergic rhinitis, not controlled after 4 to 6 weeks, refer to allergists. Here's a quick reference algorithm that brings everything together. Step 1, red flag screen. A patient comes in with nasal symptoms. First, red flags. If any red flags is present, refer, no prescribing. Step 2, assess severity. Is it mild or intermittent? So go with the second generation oral antihistamine plus allergen avoidance plus saline as needed. Moderate to severe, intranasal corticosteroid, could add second generation oral antihistamine plus saline, but use it here daily. For the persistent and severe, intranasal corticosteroid plus second generation antihistamine plus consider add-ons such as ipratropium, montelukast, depends on the situation. And then reassess the patient in 4 to 6 weeks. All patients, regardless of the severity, allergen avoidance education plus saline irrigation plus counsel on realistic expectation and book follow-up in 4 to 6 weeks. Okay, now let's do a quick summary of the key takeaways from today. First, diagnose clinically. 2 or more than 2 nasal symptoms, bilateral, it could be with atopy history, no lab required. Always screen for red flags before prescribing. Unilateral symptoms, bloody discharge, systemic symptoms, so refer the patient. Intranasal corticosteroid is your most effective monotherapy for moderate to severe allergic rhinitis, not oral antihistamines. For moderate to severe persistent allergic rhinitis, combined um, intranasal corticosteroid plus a second generation antihistamine. Counsel on correct nasal spray technique. It genuinely changes patient outcomes. Avoid first generation antihistamines, especially in elderly and children under 12. Intranasal decongestants are maximum 3 days only, and warn about rhinitis medicamentosa. Reassess the patient in 4 to 6 weeks and refer if not controlled. Okay, that's it for video number 2, allergic rhinitis. This is one of the most impactful minor ailments to manage well in the pharmacy. Because when you get it right, you genuinely improve someone's quality of life, their sleep, their work, their whole spring season. Now, if you found this video helpful, please give it a like, leave a comment with any questions, and subscribe so you don't miss our next video. We're continuing alphabetically, so next up will be calluses and corns. I'll see you in the next one. Take care and thank you for watching.